So hello and welcome to our webinar, Prenatal Opioid Use in Ontario, Overview of Current Research and Clinical Recommendations. My name is Marissa Lestry and I'm a Policy and Program Officer at the Ontario Public Health Association. Before we begin, I would like to take a moment to acknowledge the land on which we are working and the traditional people of this land. I am currently working in Toronto, and this is the land of the Anishinaabe, the Haudenosaunee, the Wendat, and the Mississaugas of the New Credit First Nation. We recognize that Indigenous practices of health and well-being have been in place on this territory for thousands of years and are maintained to this day. As a settler, I'm grateful to have the opportunity to work on this land. For those of you joining us today who are new to OPHA, I just want to share a brief mention about who we are. OPHA is a member-driven, nonpartisan charitable organization, and we focus on providing leadership around issues affecting the public's health and strengthening the impact of those who are active in public and community health throughout Ontario. If you would like to stay up to date on our work, please sign up for our e-bulletin on our website. If you would like to get more involved with our initiatives, such as our advocacy efforts, we also have the option to join as an OPHA member. I am now pleased to welcome Hilary Brown, who will be moderating our webinar today. Hilary is the co-chair of the Ontario Public Health Association's Reproductive Health Work Group, as well as an assistant professor at the University of Toronto and an adjunct scientist at Women's College Hospital and the Institute for Clinical Evaluative Sciences. I'll now pass things over to you, Hilary.
Thank you so much for the introduction, Marissa, and welcome everyone. I'm really pleased to be able to host our webinar on prenatal opioid use in Ontario. So we have two fantastic speakers with us today, and I'll just take a moment to introduce both of them, and then I'll hand it over to our first speaker. Dr. Andy Camden is a postdoctoral fellow and epidemiologist who specializes in maternal and child health. Dr. Camden's research leverages health administrative data to investigate medication use, including opioids in pregnancy, and maternal and child health outcomes. She holds a PhD in public health sciences and epidemiology and an MPH in epidemiology from the Dalla Lana School of Public Health at the University of Toronto. Our second speaker is Dr. Alice Ordine. Dr. Ordine is an active staff family physician and medical director of the Toronto Centre for Substance Use in Pregnancy at St. Joseph's Health Centre at Unity Health Toronto, an associate professor in the Department of Family and Community Medicine at the University of Toronto. Her clinical and academic interests relate to identification and management of perinatal substance use disorders. She's been a principal investigator on several research and knowledge translation projects, including the development of a comprehensive reference guide for healthcare providers. And she's contributed to guidelines on the management of perinatal opioid, cannabis, and nicotine use disorders. So welcome to our two speakers. I'll turn it over now to Dr. Camden.
Can you see my screen okay?
Yes.
Okay, perfect. So thank you for the opportunity to speak today and to share my research on prenatal opioid use in Ontario. Over the next 20 minutes, my goal is to show you how we've used population-based administrative data to understand the epidemiology of prenatal opioid use in Ontario, including the prevalence, identification of subgroups with prenatal opioid use, and select associated maternal and child health outcomes. The research I'm sharing today was completed during my PhD and was made possible through collaboration with these amazing scientists and clinicians, and also through funding from CIHR, Sick Kids, and ICEBERG. So as we all know, we're facing an opioid crisis in Canada, and I thought I'd start broadly today with a few statistics for context. So from 2016 to 2021, there have been 29,000 deaths and 31,000 hospitalizations related to opioid toxicity in Canada. Mortality rates continue to increase over the past 2 decades and now average around 21 deaths per day from opioid toxicity in Canada and around 8 deaths per day in Ontario. As you can see from the graph on the right, the mortality rates have been exacerbated by the COVID-19 pandemic. I think it's important to mention that these statistics are really the tip of the iceberg. There are opioid-related health events that occur without contact with the healthcare system that go uncounted. There are ripple effects experienced through families and communities, in addition to segments of the population who are at elevated risk of adverse opioid-related health outcomes. I thought I would draw attention to some of the work by the Ontario Drug Policy Research Network. They've been really instrumental in understanding opioid use in Ontario and also integrating evidence into drug policy decision-making. So they've partnered with Public Health Ontario to provide the interactive opioid tool with data available at the PHU level. And their work has been really helpful in identifying populations with elevated risk of experiencing adverse opioid-related outcomes. So for example, middle-aged males, people living in rural or remote areas of Ontario, including First Nations people, and more recently, construction workers. My program of research focuses on a different segment of the population who's also been adversely affected by the opioid crisis, which is pregnant people and children. So people use opioids in pregnancy for various reasons, including therapeutically for pain management or treatment of opioid use disorder, in addition to non-medical use of unregulated opioids such as heroin or fentanyl. And at the outset of my PhD, there really was limited information on prenatal opioid use in Ontario, but there were a few indicators that were signaling that this was a really important public health issue. So we saw that the incidence of neonatal abstinence syndrome, which is a postnatal withdrawal condition that commonly follows intrauterine exposure to opioids, increased 15-fold from 2003 to 2014. And we also saw that the number of infants born to women with opioid use disorder who are public drug plan beneficiaries increased 16-fold from 2002 to 2014. And in addition to opioids crossing the placenta, prenatal opioid use often occurs in very complex contexts that tend to be characterized by high rates of medical comorbidity, social risk factors, stigma, discrimination, and numerous barriers to care. We know that maternal health is a critical determinant of long-term child health, and all of these factors are really important to understand because they can compound the risk of adverse health outcomes. So at the time, there were still limitations in the existing research that left important questions unanswered. So for example, how common is opioid use in all pregnant people in Ontario? What types of opioids are being used? Who uses opioids? So our objective was to use health administrative data to answer these questions. In Ontario, we're really fortunate to have access to one of the world's largest health administrative data holdings. So Ontario's health data are held at ICES, which is a not-for-profit research institute funded by the Ontario Ministry of Health. And ICES uses encrypted health card numbers to link information from different databases. And they can also link maternal and newborn hospital records. So identifying this linked dyad is a really critical piece in understanding the effects of prenatal opioid exposure in addition to the context of opioid use. So we use several of these databases to identify maternal and child characteristics and also opioid use in pregnancy. From these databases, we identified just over 700,000 mother-infant dyads. It included stillbirths and live births from 2014 to 2019, where the mother had OHIP eligibility. We measured prenatal opioid use using several linked databases. The first is prescription opioid records. So we're really fortunate to have access to the narcotic monitoring system in Ontario. This is a database that collects information on all opioids prescribed from a community-based setting, and we are able to differentiate between opioids for pain management and medication for opioid use disorder. We also looked at hospital records. So for maternal, it could have been anything for opioid use disorder, toxicity, or adverse events. And then the newborn hospital records included neonatal abstinence syndrome or exposure to maternal drugs of addiction. And then lastly, we included outpatient physician visits for opioid agonist therapy. As you can imagine, it's pretty difficult to measure unregulated opioid use using health administrative data. So we attempted to triangulate using these different databases to come up with a measure of unregulated opioid use. So if we saw records where there was an opioid-related hospital event, but no history of prescription opioids and no history of outpatient physician visits, and we assumed that it was unregulated opioid use. So first, we explored how best to measure opioid use in pregnancy using health admin data. We identified just under 10,000 births with prenatal opioid exposure. And as you can see by the size of the circles, most of these births came from prescription opioid records, followed by newborn hospital records for neonatal abstinence syndrome, and then lastly, maternal opioid-related hospital records. So I'm showing this slide for a couple of reasons. One is from my experience, most public health units have access to 2 or 3, so the bottom for hospital records, but not necessarily linked. And while these measures are all important on their own, it's important to understand that if these measures are used as proxies for prenatal opioid use, that they really are underestimating prenatal opioid use. And we also looked at different characteristics of people captured by different data sources, and the hospital records tend to capture more higher risk patients. It's also important to keep in mind that not all infants with prenatal opioid exposure will develop neonatal abstinence syndrome, and that as non-pharmacologic approaches become more common in clinical care, this can really have an effect on symptoms and diagnoses of NAS. So just highlighting the importance of trying to look at prenatal opioid exposure with and without NAS. So we use these methods to estimate prevalence of prenatal opioid use. Over a study period from 2014 to 2019, around 5% of births had some type of prenatal opioid exposure. You can see from this dark blue line that prevalence ranged from around 6% in 2014 and declined to 4.5% in 2019. We also noted higher rates of opioid use in pregnancy among people who lived in rural areas, who were younger, so 20 to 24, and who also lived in low-income neighborhoods. When we looked at type of opioid exposure, you can see this dark yellow line here represents opioid analgesics. You can see it's the most commonly type of opioid that's used and also decreased over the study period. So we hypothesized that this decline is related to changes in clinical practice guidelines in 2011 and 2017 to promote safer opioid prescribing. This trend here is also driving the overall decline that we see because some of these other measures, such as like any use of medication for opioid use disorder or unregulated opioids or neonatal abstinence syndrome are all remaining stable. And these measures down here tend to be the ones where we see stronger associations with adverse health outcomes. So after we estimated prevalence, we were still interested in further understanding the epidemiology of prenatal opioid use, specifically the WHO. So who's using opioids in pregnancy? We identified 31,000 people with opioid use in pregnancy, in addition to 19 social and clinical characteristics. And we created a cluster analysis to try to identify distinct groups of people who shared similar attributes. So there's a little citation to the paper below where we provide really detailed descriptions of the groups that we identified. For our purpose, I'll just briefly go over the 5 groups. So the first group that we identified represented 44% of people who use opioids in pregnancy. And this group was really characterized as having short-term opioid analgesic use in pregnancy, so less than 30 days over all of pregnancy. The profile was very low risk. It really resembled pregnant people in Ontario who do not use opioids. The second group we identified represented 23% of people who use opioids in pregnancy. This group is also characterized by opioid analgesic use, but the difference with this group is that we tended to see more long-term use in pregnancy and higher rates of comorbidity. The third group we identified also used opioid analgesics for pain. This group had the highest percent of people who were 12 to 24. We also saw higher rates of hospital care related to mental illness and pain in this group. The fourth group we identified represented 13%, and they were characterized as receiving medication for opioid use disorder or had unregulated opioid use. This group had a high rate of people who lived in rural areas and low-income neighborhoods, and also high rates of parity. And then the last group we identified represented 6% of people. And this group was interesting because they had a mixed types of opioid use. But what brought this group together was really that they had high social and medical needs. So in this group, we tended to see a high percent of people with social vulnerability, hospital care related to mental illness, polysubstance use, medical comorbidity, and a high percent of people living in low-income neighborhoods. So after we established these groups, we were really interested in understanding if they were meaningful and if we could use them to see if people were more likely to experience a poor health outcome. So we followed everyone for 1 year postpartum, and we looked to see if people experienced either a drug overdose or death. Overall, the absolute risk was low, which is positive. But this graph is showing the percent of people who experience a drug overdose or death in the first year postpartum, stratified by the 5 distinct groups that we talked about on the previous slide. And you can see that there's varying degrees of risk of drug overdose and death. So the highest risk group that we saw was among that small group who had mixed opioid use but high social and medical needs. And they were 14 times more likely to experience the outcome compared with the short-term opioid analgesic group. So this analysis just showed us that we were able to identify these different groups and that they were meaningfully different. So I'm just going to change gears a little bit to child health. So as I was progressing through my PhD, there's really this growing body of evidence showing associations between prenatal opioid exposure and a range of developmental impairments in children. So we summarized this research, and we also reviewed practice guidelines that were focused on child health and developmental surveillance. So in this paper, we emphasize the need to strengthen Canadian recommendations for developmental and vision screening to support child development among children with prenatal opioid exposure. And at the time, we were really interested in looking at prenatal opioid exposure and developmental health. We were a little limited by the data, but we were able to look at preventive pediatric care, including developmental screening. So this slide here presents the percent of children who receive the recommended 5 or more well child care visits by age 2, represented in the red bars, and developmental screening at the 18-month enhanced well child visit at the represented in the blue bars, and it's stratified by type of prenatal opioid exposure. So as you can see, we identified disparities by type of prenatal opioid exposure, with children whose mothers were receiving medication for opioid use disorder or had unregulated opioid use in pregnancy as being the least likely to receive the recommended well child care and developmental screening. Previous estimates in Ontario show that around 61% of all children receive developmental screening at the well child care. So you can really see that there are these disparities, and the children who are most at risk of adverse developmental outcomes are the least likely to be receiving preventive care. We also analyzed the factors that were associated with receiving the study outcomes, and we identified having a regular primary care provider, both at the level of the mom and the child, as being associated with an increased likelihood of receiving the study outcomes. Whereas type of prenatal opioid exposure, certain demographics like area level deprivation, maternal age at first birth, and rural residents, social risk and maternal mental illness were associated with a decreased likelihood of receiving these outcomes. And I just want to point out that having a regular primary care provider was the strongest predictor of well child care. And in our study, 62% of people with short-term opioid analgesic use had a regular primary care provider, compared to 23% of people who use medication with opioid use disorder in pregnancy. This is also consistent with what we know about people with opioid use disorder outside of pregnancy, who are also less likely to have a primary care provider. I just want to point out that while we conducted large population-based studies, there are limitations inherent with the use of health administrative data. So obviously these data reflect people who are connected to the healthcare system. So we may have missed some births with prenatal opioid exposure. However, around 98% of births occur in hospital in Ontario, so the impact is likely minimal. We have most likely underestimated certain constructs. So things like social risk factors or unregulated opioid use, polysubstance use are likely underestimated in our work. And we could have overestimated certain constructs. So we have measures of opioids that are dispensed, not necessarily opioids that are taken. So there's a potential there for misclassification. And then our measurement of well child care was limited to physician visits. So we could be missing we are missing well child care that's provided by different healthcare providers, which is particularly important for people living in more rural areas. So some of the key takeaways from this research are that opioid use in pregnancy is increasingly common and best identified using multiple sources of linked administrative health data. Our findings emphasize the importance to monitor prenatal opioid exposure in addition to neonatal abstinence syndrome. The methods that we've developed allow for monitoring of the different sources of neonatal abstinence syndrome. They can also be used to follow parents and children longitudinally to better understand the associated health impacts of prenatal opioid exposure, and can be used to increase awareness of prenatal opioid exposure as a public health concern. Our work demonstrates the importance of including health and clinical characteristics in addition to opioid use to really have a full understanding of the complexity of opioid use in pregnancy. And it can aid, the identification of subgroups can aid in the subgroups can aid in the identification of higher risk diets. We hope that these findings are useful to enhance precision in public health programming and clinical care, and can inform harm reduction strategies and wraparound care for families affected by prenatal opioid exposure. Just in terms of some next steps, we currently have projects underway to investigate the impact of the COVID-19 pandemic on opioid use in pregnancy and adverse opioid-related health outcomes. I'm also working with Dr. Brown to look at opioid use in pregnancy among people with disabilities and women of reproductive age. And we are recruiting people to join a research advisory group so that we can take a more inclusive approach to this research. So if you identify as having a disability and have taken medications in pregnancy and are interested in participating or know someone who is, please let me know. And then I'm also continuing my work with Dr. Astrid Gutman on recommendations to strengthen clinical practice guidelines for children with prenatal opioid exposure. Before I say thank you, I just want to say that my goal is to conduct research that has a strong practical application for applied public health and clinical care. So if people have suggestions for information sharing, or they have unanswered questions that they're not able to address with data that they have available to them, or are interested in collaborating, please do reach out. And thank you so much for your time.
Thanks very much, Dr. Camden. So we'll turn it over to Dr. Ordine, and I'll just remind everyone that if you have questions, we'll address them at the end, but feel free to put them in the Q&A section and we'll make sure that we get to people's questions. So over to you, Dr. Ordine.
Sorry, I was having trouble unmuting myself. I'm going to share my screen again. So good afternoon, everyone, and thank you for allowing me to participate in this webinar. And thank you, Dr. Camden, for a great introduction to this topic. I'm going to change gears a bit and talk more about the clinical approach and recommendations for management of opioid use disorders during pregnancy. I'm hoping to cover barriers to identifying and caring for pregnant women with opioid use, reviewing the approach to identifying and managing them, as well as best practice recommendations. And my goal is to also share Canadian evidence or Canadian data to demonstrate the rationale for these recommendations. Some of this information was already briefly covered by Dr. Camden, but I do want to highlight the fact that we have to be aware of barriers to identification and treatment during pregnancy. We cannot jump into clinical management without acknowledging these factors. So this is a framework that was developed by Health Canada as part of best practices related to substance abuse treatment for women. And this looks at 4 different types of barriers to care. First of all, we know a lot of pregnant and parenting women with opioid use have personal factors and interpersonal factors that may be intensified by social stigma. So women who come in my office frequently display shame and guilt about using. And so this also keeps them from engaging in care. It's a barrier. Some women also will deny the extent of their use, and they may not share that with their partner either. And others will also be more worried about their other social or personal problems, such as poor housing, domestic violence, and addressing substance use may not be their priority. For many women that I see, the lack of partner or family support or even their knowledge about their opioid use is a big barrier for them actually coming for care, as well as fear of losing child custody is another big driving factor. Many of the systemic barriers that they're dealing with are related to structural or program factors, and this is the lack of available treatment and flexible treatment in their community where they're living. So as Dr. Camden has already alluded, when we are seeing pregnant women with opioid use disorders, there's a cluster of risks we have to identify. This is not just about one substance. Many women have polysubstance use. So in conjunction to opiates, they will also be using alcohol, cannabis, cocaine, and nicotine. Many pregnant women with opioid use also report overlapping mental health problems, trauma, and social stressors. So it's important to realize that when we're managing these women, we need to consider how all of these conditions will impact their ability to engage in care and follow recommendations. Understanding these intersecting complex needs will help to implement a comprehensive care plan. So pregnancy is frequently termed a window of opportunity because this is a time when women are highly motivated to make a behavioral change because of about their concern for the health of their unborn baby and the fear of loss of child custody. So when we are treating pregnant women with opioid use disorders, they would benefit from a collaborative approach with women-centered and trauma-informed principles combined with the harm reduction continuum of care. In a women-centered model of care, the women are the principals and the healthcare providers are the facilitators that allow them choice and autonomy in decision-making. So the woman is seen as an equal partner. Harm reduction, it focuses on reducing the risk of use, reducing the risk of overdose. Women may not present in an action stage of change when they first come in, but our goal is to help shift their personal ability to make those behavioral changes over time from reduced or safer use to abstinence from opiates. A common strategy for harm reduction during pregnancy is opiate agonist treatment, and I'll be covering that as well shortly. The majority of people with opioid use disorders also have experienced a past history of trauma and violence, which have resulted in maladaptive coping strategies and behaviors that may prevent them from engaging in care. So trauma-informed care involves an understanding of the potential impact of this trauma and how it will affect their ability to be present in the appointment. This may involve practitioners avoiding confrontation, judgmental interviewing style, and assumptions. It's also important to pay attention to the facial expressions as well as body language during interactions. So screening, brief intervention, and referral to treatment is a validated public health approach that can be used during pregnancy. Part of the approach includes screening, so identifying the presence and severity of opioid use, brief interventions to focus on increasing insight and awareness regarding opioid use and motivation toward behavioral change. Referral to treatment provides those who are identified at higher risk with more extensive and require more extensive treatment with access to specialty care. The evidence for screening, brief intervention, and referral to treatment in obstetrical settings stem from studies that related to alcohol and tobacco use. And as a result of this emerging evidence for improved obstetrical outcomes, many national and international organizations are recommending this approach during pregnancy. So I'm going to break this down. So screening. Universal screening is recommended since substance use can occur in any and every socioeconomic class, racial, and ethnic group. Screening based on risk factors alone may actually miss cases and exacerbate the stigma and stereotypes of substance use during pregnancy. The goal of universal screening is to identify in an early way pregnant women who may be at risk or have an opioid use disorder and may benefit from interventions. Maternal interview still represents the best screening method. So asking questions in a non-judgmental manner and normalizing the process about screening may also help to disclose substance use. Women should be screened at the first prenatal visit as well throughout the pregnancy. And as I mentioned previously, since polysubstance use is so routine, screening should also be done for alcohol, tobacco, cannabis, illicit opiates routinely at the first visit and throughout the pregnancy. So screening can be used as a way to determine the risk level of a pregnant woman for problems related to opiate use during pregnancy and the level of interventions that are required. So the 3 categories of risk that was proposed from this study is to look at low risk as those women who don't have any opiate use, moderate risk, those with continued low level of use. So this may be the category of patients who have used acutely for pain management, as Dr. Camden mentioned, or those who stop later in pregnancy. And the high risk are the women who have the ongoing opiate use disorders, whether using illicit opiates or prescription opiate misuse. This pyramid shows us that brief interventions are recommended for all categories of risk. There's a benefit for us to intervene with all of these women. And it's women at the top of the pyramid, the highest risk, who would benefit the most from referral to specialized treatment. So what are brief interventions? So these are brief counseling education advice sessions, anywhere 5 to 10 minutes. They don't have to take a long time. They can be delivered by a variety of healthcare professionals. They can be supplemented by written handouts or quick guides. And the process of brief intervention is to use cognitive, behavioral, motivational, and supportive therapies to help women quit or to prevent relapse among those who have already made a spontaneous quit attempt. So the goals at the end of a brief intervention visit is to help explore the reasons for their use, their reasons for change, to identify what the patient's personal goal is, and to negotiate a plan. And hopefully part of that plan is ongoing follow-up. Part of what I do in my brief interventions is also do counseling about the effects of perinatal substance use. And I usually break down the effects based on maternal health, pregnancy health, and then neonatal and childhood health. The consequences of opiate use during pregnancy may be related to the direct opiate effect, the repeated drug intoxication cycles, and then obviously secondary to the other associated factors such as chaotic lifestyles, poor nutrition, limited antenatal care, as well as underlying maternal mental health problems. Many studies have found that substance use during pregnancy is associated with numerous negative effects on mother, infant, fetus, and the adolescent. So this is a summary from the SOGC guideline, and it shows us the effects over various categories of harm. So if we look specifically at opiates, whether it's heroin in that time period or prescription opiates, we can see that the risks range from antenatal complications to long-term effects. We know that pregnant opiate-dependent women are at higher risk of having increased miscarriages, increased premature labor, intrauterine growth restrictions. In the neonatal time period, there's an increased risk of NAS, so neonatal abstinence syndrome, as well as a 774-fold increase in perinatal mortality. And there's also long-term effects on adolescents that have been documented. Methadone, on the other hand, the main risk involved with that is also NAS, and there's been a specific link to strabismus or cross-eyed with the use of methadone in the pregnancy. This chart is also showing us the harms of other substances frequently used along with opiates, so it gives you a sense of the total risk that someone may be encountering during their pregnancy. I do want to highlight NAS, or neonatal abstinence syndrome, or the new terminology, neonatal opioid withdrawal syndrome, because this is the biggest concern for most pregnant women and may even act as a barrier to them initiating opiate agonist treatment. We know that NAS occurs with any regular exposure to opiates in utero, specifically before delivery, and it places a newborn at risk of withdrawal if they're no longer exposed to any opiates. And we know for those infants who are treated, there's no long-term effects. However, for those newborns that are unidentified, they have a higher risk of seizures and even fetal death. So for women who are not able to abstain from regular opioid use despite brief intervention, so that moderate risk category, or for those women who meet criteria for opioid use disorder, so the high risk category, they would benefit from further referral to specialized treatment. And specifically in pregnancy, this would be pharmacological management in the form of opiate agonist treatment. So I want to highlight the two best practice recommendations during pregnancy that are very important. Integrated care programs is the first recommendation. This is something that has been emphasized by the WHO and by the SOGC and the American College of Obstetricians and Gynecologists as well. It's important to provide women with comprehensive assessments and care. So what does this mean? Comprehensive integrated care includes antenatal care and addiction treatment, in addition to assistance with multiple psychosocial needs. Now, different programs may offer a different range of services or number of services, and these may be either a single access site or multiple access site. But we know from evidence from meta-analyses done by Milligan that women who actually attend integrated care programs have improved neonatal outcomes, such as higher birth weight, fewer birth complications, and also improved maternal outcomes, such as reduced substance use, more prenatal visits, and fewer preterm births. So this is a model of care that benefits pregnant women with opioid use disorders. So an example of a comprehensive care program is TCUP, so the Toronto Centre for Substance Use in Pregnancy. And this is the program that I've been involved with since the year 2000 when I graduated from St. Joe's. We developed the program to reduce barriers to care for pregnant women attending in Toronto. We use what's called a one-stop shopping model. So women are provided comprehensive and coordinated care at one visit. So they come to see me and they can have an antenatal visit, get addiction counselor, OAT. And what we know is that women who receive multiple visits at one location are more likely to continue to attend for care as they're developing these more positive relationships with the healthcare system and the healthcare providers. At our site, we have a menu of services depending on the needs of the individual. We provide, as I mentioned, opiate agonist treatment, so methadone, buprenorphine, antenatal, interpartum care, as well as newborn care and even postpartum care. And we help to address their psychosocial needs by linking them to our fit social worker, or we collaborate with our hospital social workers as needed as well. We did end up doing an evaluation of our program because we wanted to know if we're effective as an integrated care program. And this is data from work that we did involving 121 women that received care at TCUP from 2000 to 2006. The primary outcomes of interest were to look at maternal and neonatal outcomes, and we compared from their first visit to the time of delivery. So our finding demonstrated engagement and retention in care. We had 88% attendance at booked visits. And most women were followed for a mean of 140 days, so at least 5 months in our program. We also saw improved social outcomes. So by the time of delivery, we had more women living in stable housing and fewer living with substance-using household members. We also saw reductions in maternal drug use based on self-reporting urine drug screen confirmation by delivery, so specifically reduced opioid use. Obstetrical and neonatal outcomes were also favorable. The average mean gestational age at delivery was almost 39 weeks, and the mean birth weight was about 3,000 grams. And 75% of the infants that were delivered were discharged home in the care of their mothers. So these results are consistent with the key findings from the meta-analyses by Milligan and validated the approach that we use at our site. This is also some of the data that we got from doing focus groups with women who attended TCUP. So the main themes that they brought out in their focus groups included the idea of a non-judgmental atmosphere. They felt it led to disclosure of substance use. They enjoyed coming to TCUP because they felt less marginalized and more like normal moms. They also indicated the importance of respectful communication. They found that they were getting information in a supportive way. They felt listened to, and they were assisted with referrals to community groups and other resources. And I found this interesting that women also indicated that they appreciated taking responsibility for their behaviors. In our program, we recommend antenatal self-reporting to child welfare services, and women found that if they followed that approach, the response from the child welfare workers was more positive, and we also advocated on their behalf with CPS, and that also improved our relationship. So the other clinical recommendation for management is opiate agonist treatment. We know that all pregnant women with opioid use disorder should be offered OAT on an urgent basis. Women can be offered methadone or buprenorphine as a first-line agent for OAT during pregnancy. The benefits for OAT during pregnancy are several-fold. There's evidence of decreased maternal illicit opioid use, withdrawal symptoms, and high-risk drug-seeking behaviors. There's reduced rates of prematurity, low birth weight, and infant mortality, as well as increased likelihood of maternal custody at discharge. If methadone and buprenorphine are not available or are not tolerated or effective, then sustained release morphine preparations may be considered. So we did a study where we collaborated with 2 other comprehensive treatment programs across Canada. And in this study, our aim was to provide information on methadone maintenance treatment in a Canadian setting. So until the time of our study, there was no Canadian data. We wanted to fill that void. So we included the Herzl Family Practice Center in Montreal and the Sheway Clinic in Vancouver. In the first part of our study, we wanted to describe the women attending our programs, and because we were focusing specifically on methadone, we wanted to also look at substance use and methadone treatment outcome data. What we found is that there were geographical differences in maternal demographics that pretty much matched the general population. So not surprisingly, this national cohort of opioid-dependent pregnant women were generally characterized by a mean age of 29.7 years, were white or Aboriginal ethnicity, and relied on social assistance. So even though there were differences in these maternal demographics, a lot of these were unified by the time of delivery. The other aspects that we looked at was to look at substance use, and there were different substances used geographically as well. So women in Vancouver and Montreal were more likely to report illicit opioid use, such as heroin at the time, now would be fentanyl, whereas women in Toronto reported higher rates of prescription opioid misuse. We found by the time of delivery that there were no significant differences in terms of the level of reduction in all substances. So even though they were using different types of opiates, all of the programs were able to show reduction in opioid use. And with methadone, half of these women were on it pre-conception and the other half were initiated during pregnancy. And again, there was no variations in the mean methadone dose among the 3 sites. So despite the variability in approaches among the 3 sites, the program seemed to be equally effective in reducing maternal opioid use and enhancing social stability. And we thought this might be attributable to the fact that there was a common treatment philosophy of providing care in a safe environment where women are treated with respect and dignity. We also did a second part to our study, which focused on obstetrical and neonatal outcomes. And the same thing across the 3 sites, there were not any significant differences that were not explained by the different protocols based on geography. The main finding here is that we knew that in Vancouver, there was a rooming-in approach used for management of NAS versus in Toronto and Montreal, we were doing admission to NICU. However, overall, there was a 27% treatment rate of neonates for NAS. And at that time, that was much lower than some of the reported 50 to 60% treatment rates in other studies. We found that despite the lack of differences among the 3 sites, the key again was the emphasis on mother-baby diet care through non-pharmacological interventions such as skin-to-skin contact and promotion of breastfeeding. So the combination of these 2 publications provided data regarding the use of methadone in a Canadian context and gave us some reassurance that we were using the right approach and that the approaches, even if they differed geographically, they were still having the same effects. The other medication that came in Canada was buprenorphine, and that started in 2007 when it was first approved in Canada. Then it became more commonly used by 2010. There was a gap in safety data around the use of buprenorphine in pregnancy, and we participated as the one international site for the mother study. The main outcomes of interest for the mother study was to look at NAS, and they randomized women to either methadone or buprenorphine. And the final study showed that the treatment rates for NAS did not differ significantly between the 2 medications, so approximately 50% for both. But what did differ is that buprenorphine was associated with a reduced severity of NAS. So neonates that were exposed to buprenorphine required 89% less morphine, 43% less time in the hospital, and 58% less time in the hospital receiving medication for NAS. So this is the hallmark study that helped to provide evidence about the recognition of buprenorphine as a first-line OAT agent, similar to methadone. And then since then, the next debate was around the use of buprenorphine naloxone in pregnancy. And this is a recent systematic review I conducted with one of the residents in our program that we just published. And we wanted to have documentation about the safety of the combination product in comparison to the buprenorphine monotherapy, which was historically recommended during pregnancy. So we looked at 7 studies consisting of a total of 302 mother-infant dyads. We found that there was, with buprenorphine naloxone, there was reduced maternal opiate use, and there was no significant harms, no differences in gestational age at delivery, no difference in rates of birth defects or birth parameters, and there was reduced NAS in the studies that compare buprenorphine naloxone to methadone. So this gives us also confidence that the use of buprenorphine naloxone is relatively safe in pregnancy, similar to the use of the buprenorphine mono product. So then to summarize, a woman-centered and trauma-informed approach combined with harm reduction is critical for engagement and retention in care. Screening, brief interventions, referral to treatment, and pharmacotherapy should be offered to all pregnant women during pregnancy with opioid use disorders. We know that identification and intervention at any point during pregnancy can improve outcomes. The 2 main best practice recommendations consist of an integrated care approach, as well as opiate agonist treatment as the first-line management for the opioid use disorders during pregnancy. So I'm going to stop there to allow us for any questions.
Wonderful. Thank you very much. These were both really excellent and informative. So we have a number of questions in the chat. So first, just a question on terminology of NAS versus neonatal opioid withdrawal. What is the preference and sort of the current use of those terms?
I don't think it's been standardized. I think even if you look at the literature from the US or Canada, it's really based on the researcher or the author. I think, unfortunately, NAS, when it was developed by Loretta Finnegan, it was not intended to apply to non-opiate exposures, but then the term got adopted to any exposure in utero, and that's how NOWS, or neonatal opioid withdrawal syndrome, came out recently.
I'll just add too, from a data perspective. So in the US, they have a specific ICD code now that is not like it's specific to opioids. So you can tell if the withdrawals. In Canada, we don't have that. So in my thesis, it was a discussion with my committee about whether we use NAS or do we use NOWS. And because we can't explicitly distinguish the exposure, we tended to stick with neonatal abstinence syndrome. We can identify it in approximately 75% of the cases, some type of opioid link, but because of that, we took a more cautious approach in using NAS instead of NOWS.
Some questions about the services that you discussed, Dr. Ordine. One person is interested in what stage are women invited to self-referral to Child and Family Services, and if they refuse, is a report made while they're pregnant or after birth?
So in my practice, we do a disclosure form before I actually take do any consultation. So they sign a TCUP confidentiality and limits to confidentiality document that explains the idea of if there's a concern on child safety, we may have to make a referral to CIS and all of those other limitations to confidentiality. If they have no children in their care, and if we find out they're using substances, we then don't have to make a referral while they're pregnant. We encourage them to do that self-referral, or we get their consent to make a referral on their behalf. If they don't give consent, we will make the referral after delivery. But that's not our preferred approach, because a lot of times we'll get a much more positive outcome if you can plan in advance.
A couple of questions now about screening. So the first question is, what type of screening tools would you recommend, for example, for registered nurses to use with clients during home visits? Any thoughts on that?
There's lots of recommended screening tools, but there isn't one ideal screening tool. So there's several articles talking about the variety of prenatal screening tools you can use. I think it makes it challenging because they're not necessarily geared for illicit opiates. So I think in the end, when you look at the literature, everyone has their own bias. I still think just the general screening questions around opiate use is just as effective instead of using a specific template.
Okay, and another question about screening. So the comment is certain public health issues seem to be moving away from universal screening based on evolving trauma-informed best practices. So for example, related to intimate partner violence. Can you speak to whether there may be any unintentional harm associated with repeat universal screening for opioid use during the prenatal period? And is it possible the approach may be different in settings with significantly less access to healthcare and or social supports?
Well, I can speak for Ontario. If we look at the Ontario perinatal record, it actually has boxes to screen for alcohol use, cigarette smoking, cannabis, and then other substance use. So I don't know how well people are using those boxes, actually explicitly asking the question. I guess I have a different practice because I see different patients. If they say no the first time and there's no concern addressed and the pregnancy is progressing well without any risks, then I would say the discretion of provider if they want to screen again, if they're concerned around any trauma, re-traumatization of patients. But I think it's also how we do it and the tone that we're using when we're screening. So introducing the topic of this is part of the Ontario perinatal record. We will ask all our pregnant women about the use of substances in the pregnancy to look to see if there's any exposure risks. So if you introduce it in a very non-judgmental way, that this is normal. This is not because of a specific reason for that patient. I don't think it would be as traumatizing as saying, I've noticed that you're having vaginal bleeding, so now we're gonna keep screening you for opioid use and cocaine use. So I think it's again in the language and even our nonverbal language.
Sure, that's a great point. I think one of the challenges in this area, of course, is resources outside of large urban centers. So obviously you have a really unique and impressive program where you are. One individual has asked if there's a contact for TCUP in terms of providing resources to people outside of Toronto that may have questions regarding substance use during pregnancy, or are you aware of any other resources outside of sort of our major urban centers?
So there's other programs that have sprung up in Ontario over time. So in Hamilton, there's a similar program. In Toronto, we also have our sister hospital, St. Michael's Hospital. They also have high-risk pregnancy clinic. I think in Toronto, many of the hospitals have taken on to provide care to substance use during pregnancy. I'm trying to think of if in Sudbury, I know there were several providers with some interest in this care. In Kingston, there's Dr. Adam Newing providing this work. So there are pockets of the province where we have providers providing this level of care. So I'm familiar with certain areas of the province where we can connect you to other specialized services. And that's part of my goal too, is that we don't want people traveling for 3 hours to come to our center. When I first started, we used to see people within a 3-hour radius, and now I'm trying to narrow it down to about an hour radius if possible, because I don't think it's great that we have patients leaving their communities come to Toronto for care.
For sure, travel is definitely an important consideration. There's some other questions here that I'll address in a moment about other resources, but I'm wondering if either of you would like to comment on priorities for future research in this area. Clearly, this is a growing public health issue and it's evolving. So any comments on that?
I mean, I think even though we try to do several clinical studies related to the work I've done, I know how difficult it is to engage this patient population in long-term follow-up studies. We even did a small developmental outcome study at our site where we used data from our neonatal follow-up clinic to see what happens to the development of these infants. We only had data up to 2 years of age, and the attrition rate by the second year of life was over 50%. So I think the challenges in this patient population is how do you get that long-term developmental outcome data and the maternal outcome data? How do we, we look after these women so much when they're pregnant, but then what happens beyond that? And what happens to these children? So I think that's the biggest gap that we are facing.
Yeah, I agree. The long-term health outcomes are really important. I think also conducting more inclusive research as well. I think it's really powerful and helpful to understand people's experiences and their needs. And I think interventions too. I feel like we can always use more research on different interventions and how best to support families moving forward is really key. And as Dr. Ordine mentioned, the importance of wraparound care and a one-stop shop. Like I think there needs to be more evidence on that type of care so that we can see expansion.
Pharmacologically, I mean, there's been lots of advancement with the introduction of buprenorphine in pregnancy. That's being used more and more safely. But I think beyond pharmacological treatment is where the challenges still lie, and maybe even adoption of some of the pharmacological recommendations. I'm sure there's pockets across Ontario that don't have the same access of care to buprenorphine or methadone. So I think even though the recommendations are there, my biggest concern is how are these adopted at a regional level. And the geographical differences. I mean, we saw that in a study across the country. We know there's geographical differences. And then what we also saw is that every program had to develop some niche ways of dealing with certain geographical issues. So how do you do that in Ontario? For example, in Northern Ontario, right? We need some specific interventions for that patient population.
Very interesting. And perhaps a related question that's more specific is, has there been any research on the use of safer supply medications during pregnancy? Any comments on that?
That data is very limited. There's only been, I think, one case report looking at injectable OAT that I found in literature last year when I looked at the subject. And then this one so-called case report, it was 2 women. But it's a very small literature. So we're looking at 1 or 2 case reports only at this point in time. So that does not imply safety. So I think in pregnancy, the goal is harm reduction, meaning don't provide a service that we don't actually have any data for benefit.
And I've seen the same 2 case studies, so.
Research in that area. There's another question here on a slightly different topic on resources that review the use of psilocybin or mushrooms and the effects in pregnancies. So any comments on resources available related to other substances?
I'm trying to think of we do have some guidelines, but I don't think specifically dealing with mushrooms per se. And I don't even think there's any data outside of the main category of substances that we see a lot of data on are opiates, alcohol, nicotine, cannabis, and even now some the amphetamines. But I don't think I've really seen any outcome data related to mushrooms.
Great, thank you. And last question, I think this is a specific question about available services. And not to put you on the spot, but are you aware of any services in York region? So other than St. Mike's and St. Joseph's, any other services you're aware of?
So in York region, there is the York Region Addiction Counseling Services, but for medical treatment, there isn't a local champion that has taken on this work, unfortunately. So we don't have a specific service that we would refer patients to. We do have patients traveling from York region and beyond to see us, but I think the goal is, even if they, for example, because I offer a menu of choices when they come to teacup, they may still get prenatal care close to home and then maybe do some addiction counseling with me. So and as long as we have communication between the different providers, that's another model of having this integrated care amongst 2 sites instead of 1 site, as long as the providers know what their roles are and what the interventions are that are being provided. The same thing can be done in York region. That can be a provider for addiction care and a provider for antenatal care, as long as that can be, the communications are open.
Thank you. So I'm just looking at the time. We have about 2 minutes left, and I think Marissa might have some closing remarks. So I'll turn it back to her. But first, I want to thank you again, Dr. Camden and Dr. Ordine, for a really fantastic presentation and a great question and answer period. So thank you, and we really appreciate your time. So back to you, Marissa.
Thanks, Hillary. I just wanted to echo those remarks. Thank you, Dr. Ordine, Dr. Camden, and you as well, Dr. Brown, for joining us and organizing this today. I just wanted to let everyone on the line know that we will send a survey out this afternoon, and just ask if you could please fill that out quickly. It's a couple of questions. All responses are anonymous, and all suggestions gathered help us to improve our webinar planning going forward. So hope you have a great afternoon.